Welcome to Nursing Networks. I'm Mark Foreman, the Dean of the College of Nursing, and this is a really exciting evening. I think this is the largest audience ever for Nursing Networks, so that's really exciting. The other thing that's really impressive by our audience tonight is it represents the entire spectrum of the Rush nursing family, from students, staff, faculty, alumni, partners, and friends. So that's really great that you joined us this evening to be part of this discussion. As the 2015 celebration of Nurses Week comes to an end, and today is Florence Nightingale's birthday, so it's really a prestigious day to have this conversation. We're going to focus on interprofessionalism, which is an historical core value of Rush. Although interprofessionalism is new to the national conversation on innovations in healthcare professional education, interprofessional education and practice has a long-standing tradition at Rush. One example is in 1997, the John A. Hartford Foundation funded 8 sites across the U.S. to study geriatric interprofessional team training, known as GIT. Now, 18 years later, Rush remains the only program of the GIT projects across the U.S., we are the only remaining site. I think that's a really strong testament to the enduring value of interprofessional activities at Rush. So it's my pleasure to introduce a long-esteemed colleague, Dr. Marcia Murphy, Associate Professor of Adult Health and Gerontological Nursing. She's also the Program Director for the Adult Gerontological Advanced Practice Programs, and, to say the least, or not the least, the President of the Rush Presbyterian St. Luke's Nurses Alumni Association. Dr. Murphy.
Good evening and welcome, and thank you very, very much, Dean Foreman, for that introduction. As president of the Rush Presbyterian St. Luke's Alumni Association, I am truly honored to work with a terrific board of directors. Several members of the board are here tonight. If you would stand, I would love for, thank you so much. I think we have a few more. Thank you so much for your service, and I encourage all of you at the end of the evening, we have time for networking, to connect with us as a board to learn more about the Alumni Association activities and how you might become involved. This is a fabulous collaboration of the leadership of the professional nursing staff and the Rush Nurses Alumni Association, and what a wonderful celebration. I have the distinct honor to introduce our panel speakers this evening, who are Rush University Medical Center leaders. Dr. Jan Odiaga is our first panel presenter, and Dr. Odiaga is an assistant professor and program director of the Pediatric Primary Care Nurse Practitioner Program. Diane Gallagher is an Associate Vice President of Clinical Nursing Operations for Women's and Children's Nursing here in the Medical Center. And Dr. Stephen Rothschild, a family physician, associate professor and researcher in the Department of Preventative and Family Medicine here at Rush. So without further ado, we will begin our panel presentations, and following the presentations, we will have an opportunity for dialogue and questions. Jan?
Well, good evening and hello, everybody. I wanted to thank Dr. Mark Foreman and Dr. Marcia Murphy for inviting me to speak this evening and to be with all of you. I'm both honored and proud to be part of this group and to be part of the innovation and change within Rush and within Rush educational system. As Dr. Mark Foreman pointed out, today is our founder's birthday, Florence Nightingale, who is the founder of nursing and nursing education. So imagine, here it is, almost 200 years later, and nurses are still the leaders in education and in nursing trends. So as key leaders and change agents, I'm glad to be able to present to you this evening interprofessional education here at Rush. And as a panel, we hope to encourage some open discussion about what is interprofessional education, what it is not, and why is it important. So interprofessional education. I believe one of the biggest changes that you'll find that has happened here at Rush is we are no longer playing in sandboxes. Remember when you were in school and you were learning about your professional identity, about your role? It was really about you. It wasn't about engaging with or from or learning about each other. It was about your professional role. Well, today, we've moved out of our sandboxes, and we are learning to play what I call sweet harmony. Together, as a team, we focus as one and how to improve healthcare outcomes for our patients and those that we serve. Well, in 2010, the World Health Organization gave a formal definition to what is interprofessional education. It is students from two or more professions learn about, from, and with each other to enable effective collaboration and improve healthcare outcomes. And I'm very excited to say that Rush has adopted this definition, and it has become part of our strategic mission and plan for the future of all Rush students from all disciplines across all colleges. So, how do we do it? How are we going to prepare our students for the future? How are we going to provide interprofessional education? And what will its outcome be? I just want to take a moment, if I can. I'd like to have Dr. Joanne Miller stand up or wave her hand, please. And if Dr. Rose Sahida is here, I'm not sure. Okay. Well, anyway, I wanted to acknowledge my colleagues because I was able to, with Joanne Miller, to receive a very large HRSA grant on interprofessional education. Did it just change? Yes, sorry. It flipped before I wanted it to. Sometimes that happens with my emails too. So the attachment isn't there. So anyway, we were able to have receive a very large HRSA grant for professional education. And it's called Interprofessional Education Pediatrics Through Aging. And with the support of the Higher Learning Commission and a Quality Improvement Project that Dr. Rose Sahida has engaged the Rush University, we have made a commitment to interprofessional education. And our outcome, we hope to be that we would like to prepare our students to be deliberative. We want them to work in interprofessional teams. We want to optimize the health and quality of life for individuals with multiple chronic diseases. We want to prepare a workforce-ready team that knows how to engage patient-centered care. Well, there's a lot of different ways to go about interprofessional education, but it's different than what maybe you think. It has to be didactic and experiential. We have to apply, if the experiences have to be meaningful, and they have to be extremely intentional. You have to plan for it. Let's face it, we've got a lot of colleges and a lot of disciplines here. We need clinical experiences that reflect what we have been teaching them. They have to practice, and they have to practice a lot what they have learned here. And then they have to reflect on it, because this has to be who they are. They have to learn not only their professional identity, but they have to learn to work as a team and know that's the best outcome. So what is not professional education? Well, I remember a long time ago, being a graduate of Rush, that we sat in a large lecture hall with many different disciplines and learned physiology together. But we sat in our own little groups. So the nurses sat with the nurses and the medical students sat with the medical students. So that really wasn't interprofessional because there was nothing intentional about it except physiology. So that's not interprofessional education. And how about when we had some other faculty from another discipline, maybe someone from speech and language pathology, who came in to speak to us about a child with cleft palate? Well, that really wasn't interprofessional because we didn't talk about how we interact with each other to take care of the patient. We learned from somebody else, but it was not intentional. Or how about it when you were a young clinician and you wanted to speak up in a group and you wanted to be part of the team, but you just didn't think you were there. So you weren't involved in the patient care and you really weren't part of the team outcome. So this is not what we want our students to experience. We want them to experience interprofessional education, clinical opportunities to improve the health and outcome of all of the patients. So why do we need it? From so many reasons. Because no one profession or any agency can provide for all the client's needs, so there is an absolute moral obligation to cooperate with each other, others who may share a professional responsibility to help patients and the communities. We need to work together as a team. We have to prepare our students to work with the population that they're going to be serving, and the data today is frightening. The population is getting older. We have more immigrants. We have different races and a lot of diversity. And along with all of that, chronic diseases is going up and up, not only with elderly, but with children too. So we have to prepare our students to be we have to educate them, and we have to prepare them to work collaboratively as a team, and that's just what we have to do. So we have to take our students from the classroom, teach them about the roles of each other, the values and the expectation, let them emerge as a team where they can communicate openly with each other, to share the common values, so they can work together as a patient-centered team and provide the outcomes that we're looking for. I'm getting a little flash of signs. My time's about up. So, in a nutshell, where can Rush lead? We can lead right here as a national leader. We can align our teaching with the practice across the street. The practice will teach us what we need, and our education will prepare our students to be in practice. So with that, I'd like to say thank you for your time, and Diane Gallagher will be the next speaker on the panel. Thank you.
I like to wander, so this is going to be hard for me to hang on to this and talk to you. But what I want to say is if, in fact, art imitates life, we are in good shape. Those of you, and I'm looking out, and you know who you are, in my age group, remember when you were younger and who the heroes were? Who remembers the Lone Ranger? Superman? We talk about Batman. Robin was just a sidekick, let's face it. Just comic relief. Thinking about what you know, and that would be the younger folks in the crowd, who are the heroes now? This is the part where people can shout out things, but I'll take care of that for you. Think about the Avengers, a group of different talented people coming together to solve a problem. My son's favorite, the Ninja Turtles. My daughter's favorite, Powerpuff Girls. They were all teams. So what about healthcare? Back in the 70s, now I can say back in the day, I'm at the age where I can say back in the day, in the 70s, when you look at the average number of people that a patient interacted with, and you can guess in your head and see if you're right, so guess in your head. Okay, and the answer is 4 to 5. In the 90s, another moment to guess in your head. How many people did the patient engage with? 25 people in the 90s. Those of you who are in healthcare now, think about the number of specialties that are out there that come together to take care of your patient. And then think about the problems that come along with that. What comes along with that? They don't talk to each other. This person's making this decision. I see a lot of nodding. There is a problem. What we did then will not solve the problems we have now. And so with that, I'm going to talk to you a little bit about what we are doing here at Rush in terms of pulling together teams, interprofessional teams, that I'm super grateful is being taught in the college, because I do believe it is the generation that is coming up that is going to make the difference when those of us who are sometimes a little stuck retire. So how many people, just by a show of hands, have heard of crew resource management? So numbers of people, because you're from Rush, so of course you might have some idea about that. And another thing, the hospital version of it is team steps. So what is crew resource management? Just in a quick nutshell, since you mostly know what that is, it is the process developed by aviation to deal with the problems that they were seeing. They stopped blaming individuals and saying it was the pilot's fault, it was the engineer's fault, and said, you know what, we're having problems, people are dying. We need to figure out how to work together as a team. So we're talking about high-risk, complex situations, and they looked at optimizing the team performance. What was their focus? Safety. It was not good advertising to have people dying in droves in a plane air crash, which again, in the 70s, was happening on a semi-regular basis. It had to be a systematic process that was flexible. You know, how do you deal with geese flying into your engines and having to glide land into the Hudson isn't something you specifically write up about, but you use your resource management training to solve problems like that. So what's the basic principle? It's moving from blaming the individual, which, by the way, is very satisfying, is not helping. It is about looking at the systems and talking about reliable team chemistry. The kinds we talk about team chemistry in sports, like how do teams work together? They practice together. They learn each other's moves. And in healthcare, we can't have that stable roster because people take vacations, they float, the residents change service. How do we create team on a daily basis when the team members are changing? And the last thing is, and I love this part because it was very, in a way, depressing, but also a relief, that knowing that if we are human, no matter how well trained or well intentioned we are, error is inevitable. It is inevitable. And this is about trapping that error, mitigating it, and being safe for our patients. So is team chemistry important in healthcare? I think that is why we're teaching it in the colleges. But look at some of the statistics around what happens when you look. This was a look at surgical cases, a high number of surgical cases. What was the breakdown when you saw a complication? 43% involved communication breakdown. Looking at people dying from this and people being disabled. So the point being here is we need to do something different. We've seen that with what we talked about, CLABSI errors, when we look at central line infections, et cetera. What is it going to take for all of us to pull together to speak up and address these issues, and how are we going to do that in healthcare? So what we did at Rush, and this is just this is our experience of, we did crew resource training back in 2008. We're starting to look at big numbers and small numbers in terms of, are we getting any better in terms of our safety index? And we see gradual improvement. What's it based on? It is based on teams working together. Our most recent wonderful example that I wish I had the slide for, but I didn't get it up there, was our TRAPU, which is the trach-associated pressure ulcers. Looking at 20% average of adults having pressure ulcers from their trach, working with an interdisciplinary team, working with evidence-based, putting together a checklist of this is what you are going to do, and then having a 9-month consistent decrease of less than 1% of patients having pressure ulcers related to their trach is amazing. So when people start using the skills that are in crew resource management, you see change. And it is about all of us working together. We cannot work in isolation. And this is not, for all of us in healthcare, a matter of if we're going to do this, it is a matter of how long is it going to take us to do it. The airlines took a couple of decades. They like to say, well, healthcare is way ahead of the game. I'm thinking, sometimes it makes it hard, but we see the difference. So I know this is all right, we're going to have to click a couple times to, whoops, click back. What's our experience at Rush? We've had over 4,000 team members involved in the training for crew research. You can see the number of units that have been involved, and there's been over 26 crew tools specific to the post-training, but what you see is in our Rush Ray training and any of our quality, we're to work on standard checklists, evidence-based, standardized communication, acknowledging that communication. And do we have a way to go? Absolutely. You don't want to be satisfied with where you are. This is a garden. It requires tending and replanting, and that's what we're doing. And what do we see in the outcome when we look at Leapfrog, looking at getting an A rating for patient safety for the 4th consecutive year, UHC moving from 18th to 5th. These don't happen by accident, and it doesn't happen in silos. People working with each other in healthcare for the betterment of the patient is what it's going to take. And using crew resource management is one of the ways to get there. That's it. Thank you. And now,
All right. Thank you. I'm really pleased to be here as a non-nurse. This is a really exciting opportunity for me, and it's a very exciting opportunity because I feel like I've worked with half this room on one occasion or another. I've had a project together, so it's a bunch of friendly faces, except for the people I've ticked off over the years. So, so my job is to talk about sort of how we take the educational model that Jan talked about, how we take the experience that Diane talked about, how teams transform, and how we're spreading that throughout the institution, because these are individual activities that are going on all around the institution, but how do we weave it together into a coherent whole? And how do we involve everybody in the room in this process? Because this is a transformative process. So when you work with students, and they're seeing us, what they may see is a nurse talking to a patient, a physician talking to a patient. They see this individual interaction. But you and I know this is not the story at all, as was described so well by Diane. I was guessing those numbers, having been there in the 70s and 90s. What is really going on is this much more complex web of interactions, some of which go through the patient, some of which don't even touch the patient, but are affecting outcomes. And they include people we've known for years, physicians, pharmacists, social workers, psychologists, some newer players on the scene, case managers as we get more into population health, the rehab team. I started to run out of space. I think I had originally thrown on this slide community health workers, patient navigators. We have jobs that didn't even exist in the 70s and the 90s and the 2000s. And it's an expanding roster as healthcare becomes more complex. I tell my students, we've taken care of all the easy problems. Well, we are the victims of our own success. We are left with problems that are much more complex. And they're not only complex because the individual illnesses that we cope with are more complex, but because the social issues are also complex. Because we're not just responsible to each individual patient, but we're responsible for health equity. We're responsible for ensuring that we improve the health of the public, not just our individual patients. And that, as has been said repeatedly, is a team effort. It's not going to be one of our disciplines or one practitioner. So this is from the World Health Organization. The challenge is clear. We are being tasked with dealing with an increasingly complex health environment, with increasingly complex problems. The good news and the opportunity is that the more that we practice together, the more that we train together, the better the opportunity for them to be part of a collaborative, ready workforce. We don't have to wait until our students get out in practice and then kind of make them figure out how to work together. We can begin the day they arrive at the College of Nursing, the College of Medicine, etc. We can prepare them and make them better. And in doing so, move from this fragmented healthcare system to a position where the system is stronger. Dr. Goodman, as we talk about this effort, says he wants all of our students to graduate with that extra piece of DNA in them, that recognizable Rush quality that says they understand how to collaborate effectively in teams. And so that when a nursing graduate goes into the workforce, they go, oh, you're from Rush. We know what you know. When our medical students graduate, when our OT students graduate, they are recognized for this. So that's our opportunity. Our strengths are the things we've talked about. We have experience in education, and I was so glad when Dean Foreman mentioned the Geriatric Interdisciplinary Team Training Project. A lot of us were there at the beginning. I'm seeing my friend Kathy Catronbone, and we've worked on that project for close to 15 years, 4,000 students later. This has woven through so much of what we do. We have, as was just discussed, high-functioning team units. We have our practitioner model. The people who are teaching are people who also touch patients. We understand both pieces. I was commenting earlier that the tower which is really the pride of the medical center, was built very consciously to facilitate interactions across disciplines. It used to be in the old buildings, and we'd go off to our separate corners, and nurses would be over here, the residents and the doctors would huddle over here. That's not really possible in the tower. It's an open, collaborative environment, and if you make the shape work, the processes begin to follow. We have a robust background in research on interprofessional care, crossing over the biomedical and the behavioral and the social. And most important, we have the commitment and the work that Rose Suhaida is doing leading up our Higher Learning Commission recredentialing project for the university. Rush chose for our quality improvement project. We could have done anything. We could have done student satisfaction. We could have done, course ratings, job placement, etc. We chose interprofessionalism. That's what we're putting our marker down on. That's a very high-risk thing to do. So we have to mean business with that. So a group of us have come together over the years to form what we're currently calling the Rush Center for Interprofessionalism. This is a collaborative of 35 faculty and clinicians, many of whom are sitting in the room, who have collaborated to apply principles of interprofessionalism in both teaching and practice. Those are some of the names there, and you'll recognize a couple of the people who have spoken, as well as other people who are sitting in the room. I mentioned Kathy Cattermole already, Beth Ann I saw in the back. We have Diane, who's already spoken. I don't know if Renitha is here. Dr. Halstead. Who else am I missing here? Joanne, Melinda, Jan. You guys are dominating this. Let's just name it. This is a very nursing-dominated process, but you don't own it completely, and it is an interprofessional team. We have chaplains, we have physicians, we have students from all the colleges, we have health systems management, we have everybody. It's everybody in. And as a result of this push and the wisdom of leadership, for Rush today, our strategic plan going into the 50th year of the reestablishment of the university, and it will be coming up in 2022, mark your calendars now. One of our key strategic themes is to be a national leader in team-based care and interprofessional education, putting patients at the center. We talk all the time, this has got to be about patient-centeredness, about safety, about the environment, of making things better from a patient standpoint. So how do we get there? We have to begin with the end in mind. So we oftentimes think about the teaching, how do we teach these things? What we really are beginning with is that triple aim. Safety, outstanding patient experiences, integration of prevention, reducing costs, reducing health disparities. We want it all, and we're only going to get there via team. So this is the center model. We're doing education, practice, transforming the culture of the institution in order to deliver value, which is not just improved quality, but lowered cost and better outcomes. Working together, we can make this happen. So this is my final slide. For those of you who work with students, make the invisible team visible. Talk about who they're seeing and who they need to be aware of. Coach the students that you work with on effective collaboration. Model behaviors. How do we disagree with each other respectfully? How do we come to healthy team processes? And then innovate. Think about new processes where you practice and help our students participate in that. Together, we can make this possible. Training the next generation so that Rush is recognized as a leader in team care and that the care that our patients get is better. Thank you very much.
Questions? We have an opportunity now for dialogue, and do you have questions for any of our panel members?
Marcia, I just had a question about how other hospitals rate. Certainly, as a longtime employee here at Rush, we have had an incredible environment to grow up with under Luther Chrisman and so forth and so on. But I'm wondering, how do we relate to other hospitals? Where does Northwestern fall? Where does U of C fall? Because I'm doing some research at both of those hospitals, and I won't say any more.
And we may have some folks in the audience from those settings, and we would love to hear some of your experiences with interprofessional practice. But do any of the panel members have a response for Anne Marie?
Well, the one thing I was going to, we were just chatting about the Tribune article in terms of the CMS ranking, 5 stars, 4 stars, et cetera. And a small percentage of Chicago and the Colorado area got 4 stars, and Rush was one of them. And just to your point about mentioning Northwestern, they had 3 stars. Point is, people are being evaluated. It is competitive, and so that when you look at you can look a lot of this stuff up online now to say how are you doing related to other hospitals, like the UHC data I was showing. I have our data. I don't know how we compare to others, but I'd say 5th place out of 101 is pretty good. And looking at Leapfrog, which is an independent business group, saying, hey, where do we want to invest our insurance money? And saying Rush gets an A for patient safety is an impressive step for us. I don't know. I mean, like I said, you could go online and start checking out where you want to go to your, physician, and the insurance companies are probably doing the same thing. So as I say sometimes in crew training, greed is good. If it is money motivated and benefits the patient, it's really a nice synergy to say we are going to move forward and we're going to get better. So that's all I have about it.
I was just going to add a single comment. If you remember Jan's slide early on, there was a cycle of teaching informing practice and practice informing our teaching. The RCI, the center, has been going around trying to find people who are doing this well across the country. And what we found is we have universities we can go to who do a really good job teaching, but they don't have health systems where teams are practiced. We have health systems we can go to and point to that are doing great team practice, not doing the teaching. What we're doing, what we've already got the foundation doing, and what we will continue to strengthen over the next few years, is that integration, and that's where we will stand out. I think I would put up what we're doing against anybody nationally at this point.
Yeah, there's very few large universities have the combination of both education and a medical center, and so we are one of the first doing that.
Are there other questions? Yes.
I have a couple comments. First off, I've been at Rush here 10 years. This is my 10th year at Rush, so cheers to that.
Congrats.
As a technician before I became a nurse, so I've been a nurse now for over 5 years. Jane, I completely understand what you're saying, and I feel that we at Rush here need to use more of a debriefing tool as when it comes to debriefing on our patients and debriefing when there's a difficult situation, and not only debriefing as far as for patient improvement and improvement in processes, but also improvement on your own self, and as far as a nurse being able to deal with these critical situations that we have to deal with. And I feel like a debriefing tool is underutilized here at Rush, and we definitely do need to debrief more on these critical situations that we have.
Yes, I think that's a great point. There is a lot of moral distress that happens all the time for people in healthcare with the critical decisions. And one of the things we are working with our students and with crew is Team Steps. And Team Steps is a program that talks very in-depthly about communication, briefing, debriefing, huddles, cuss, how to stand up for yourself and be able to speak up and be confident in what you say, about situation monitoring, and to work together as a team. So these pieces are all being added as workshops. And to date, we have completed in the last year 9 student workshops and 7 faculty development workshops, so that the faculty is prepared to teach and the students are also learning the content. So in the last year, we've touched 450 students and 129 faculty. So soon this will be the norm and the culture of Rush.
And to add on to that, for our next rollout is for our medical and surgical acute care units, and we do give examples of where huddles are actually working well. We use our OB and MICU huddle when they deliver babies not in labor and delivery, and how they do pre-briefs and they do huddles afterwards to talk, what did we do well, what can we improve on, and how can we make those improvements happen. And when you share that with people, they want more of it. And so one of the things that we have to do is how do we create a structure that supports people to get to those huddles, to do them concisely, to do them timely. And as you said, it's an evolution. And when people start seeing things that work for them and they get something out of it and they see the impact on patients, it's not a push to make people do things anymore. They want to do it.
You know, I also wanted to comment on Jean's crew training, because I have also been to crew training. Again, I've been here for 10 years. So I feel like the RN2 here at Rush, as I'm a dying breed. We have our Rush lifers and we have our, you know, sort of RN1s that then progress. So I feel like the crew training is absolutely essential to me and my longevity here at Rush. And I feel like that the more the crew training, I have my wings, you know, so I think it's, again, underutilized here at Rush. And I feel like the crew training was a good point to bring up and a good thing to keep longevity as of staff longevity and the Rush lifers, as I term them.
Marsha, can I get a quick comment in?
Yes.
I think this is a lot about culture and the culture of a place. And, you know, we can talk about individual pieces, but ultimately what we're doing is building a culture where this is the norm. And I flipped through that slide quickly because I was getting the high sign from Megan. But in reality, it really, the more embedded this is in everything we do, or if you're going back home to another institution, bringing that as a cultural change, because, you know, what's that expression, you know, culture eats policy for breakfast. We know, you know, all of you know the first-year resident that you have pulled their, you know, fat out of the fire on multiple occasions, and somehow by the time they're third-year residents, they're arrogant and they're giving you orders. You know, we have to change that world, and that, you know, that's culture. That becomes, that's no longer acceptable, and the more we can make that kind of, that's not the way we practice. That's when things begin to change, and that is what's happening here, I believe. We have a long way to go, but that is the message that is coming from the top down and from faculty like everybody in this room.
And students up. The students really want to be part of a team.
Yep.
It's stressful. You know, there's very high acuity patients. There's a lot of problems. It's scary out there. And if you can have someone to talk to and bounce ideas off of and feel like you count and being part of the decision making, it's better. There's many fewer errors. We communicate better. We share. It's much better. And I just want to say about giving orders. You know, that's kind of a button, I guess, of mine. Not that someone's giving me orders. But, you know, we often do that to our patients. We give them an order. You know, we tell them, you must go do this, go do that. Well, we can't do that anymore. The patient, really, we have to engage that patient to be part of our team. That is our main core piece. We all work around them. They have to be engaged. We have to communicate with them, their family, and their caregivers. So it's patient-centered all the way through.
That's a great conclusion to our panel, Jen. Fantastic, fantastic. Thank you all, and thanks for the dialogue. We're going to move on to the next phase of our program. I, again, have the distinct privilege to introduce our next speakers, who are leaders here at Rush. Dr. Eric Zach is the president of the Professional Nursing Staff and Oncology Nurse here at Rush, and Dr. Cynthia Bargenier is the Chief Nursing Officer here at Rush University Medical Center. So they will discuss current initiatives of the professional nursing staff, as well as an update on the Rush Nursing Magnet journey. And thank you both very much for being here to present. So we'll begin with Eric, and we will have an opportunity for questions following this part of the panel as well.
Hello, everyone. Okay, so I am here to talk to you about what we're doing over in the hospital. As a staff nurse, I did see a problem that affected my unit, and I did something about it since Rush wasn't addressing it. And so what I saw, I want to tell this story, was briefly, was that we had a dying patient, young girl. She voiced she did not want to be intubated. And then she went unresponsive and started to decline. And the nurse, I wasn't the nurse, but a nurse taking care of her, mom was at the bedside, and mom was adamant that she wanted her daughter. She wasn't ready to let go of her daughter. and then her to go down to the ICU and be intubated. And she was a DNR per her choice, the patient's choice, and the mom was very angry at the nurse, trying to do the right thing. Again, there was a DNR order. But she escalated it, and so the nurse didn't do anything wrong. She was just informing them what was happening, the changing status, et cetera, trying to help mom. But ultimately, they had to go up through the chain of command, call a doctor, and actually send her down to the unit and have her intubated. And ultimately, the mom had to pull the plug on the daughter. So it was very distressing to that nurse, and to this day, she still can't talk about it. I mean, when she has talked about it, she's cried, and it's just very traumatizing for her. And I saw the mom yell at the nurse. I saw the nurse practitioner yelling at the nurse. I saw the attending physician say, "Not my problem, it's between you." And I thought we could do better. And that was the impetus to change that. And so I sought out evidence-based program called Short Center Rounds, and I applied for a grant to receive it. I won the grant across the country and brought that program here to Rush. And now we're into our 5th year of offering that. And so I presented this poster to Magnet last year, and just is really focusing on the moral distress that staff feel. Again, it wasn't anything the nurse did, but it was a situation she found herself in. And there was no support for that. Ultimately, it made a good poster to show our baseline for the nursing engagement scores, but as a bedside nurse at that time, I didn't follow that. I just saw what I saw and dealt with it. But looking back, the data was pretty amazing what we've accomplished over that time. But ultimately, and in our mission here at Rush, to provide compassionate care is very important. And Short Center Rounds is a public forum. It's one avenue to help deal with moral distress and promoting that compassionate care. So here, the format of this, if anyone's unfamiliar with it, it's a multidisciplinary panel, okay, getting every discipline together in one room, physicians, nurses, social work, students, chaplains, every member of that team, whoever wants to attend freely, talking about a specific case, generally speaking, and share those perspectives of all those players involved. What was distressing to them, what bothered them, what they think of home, on the way home, and things just to share their insight, their perspective, so that others could feel that, walk in their shoes, and understand some of that baggage that they carry. And then we spend the last half hour with a discussion in that room about a certain bigger, broader issue that may be. And then just hear other people's thoughts, and even though it's not like grand rounds where there's teaching points and you learn things, you do leave that room taking other people's insights and understanding things a lot differently. But we focus more on the psychosocial and emotional aspects. So again, here, we provided this here at Rush. We have about 2,000 nurses. About 7,000 people attended the Schwartz rounds over those 4-year period. And what I did was I just focused on the nursing engagement scores for how our hospital deals with stress and burnout. Even though it was a multidisciplinary effort, I just focused on quantifying the nurse impact. But this is a slide of all of our attendees over those 4 years, and obviously the 42% were nurses, bedside nurses. Again, in other programs, it's difficult to get to the bedside nurse to these programs because it's an hour lunch, etc. And here we got to walk across to the room 500, but we still have a great showing, and that says a lot to Rush about supporting their nurses, even managers staying back to watch the floor to allow their staff to go to the program. And here, interestingly, 24% of that are students from Rush University. Medical students, nursing students, and all the therapy students actually attend as well. And it's not required, but they are affiliates of PNS, and so they're certainly welcome to attend. And we take that cost for the food. And then we also have other, which is a big category, and this would be anyone that doesn't fall into the typical profile. We're very proud of who we've attracted to this program. And it really has, talking about the culture, it has begun to change the culture here at Rush in that we were trying to hear each other out and understand from their point of view why a physician chose to do this or what was that. And we've had amazing sharing on our panel, physicians sharing, I felt attacked by my staff because I made this decision to do this and this and this, but here's why I did that. And so people can understand that. Here's our evaluation for that, just looking at that over the 4-year period. And I just want to stress that, we focus on that quality of that program, and we're still, 4 years later, not stale. Getting great cases, great presentations, and again, it's really all about the panelists and about the whole room talking about taboo topics that we've never talked about. And then this was just the nursing engagement that we did, showing the gradual increase, again, from bottom of the barrel all the way up to benchmark. And this year, unfortunately, we trended back down. These are just some quotes, but due to time, I'm not going to be able to read them. But it really has had an amazing impact on those who attend. Okay, they're very happy to come, and they keep coming back, about 50% repeat attendance. So we're just very proud that as a staff nurse, as a bedside nurse, Rush has supported me to bring this program here and really to involve all disciplines in what was theory in the past, but now we're making it reality. Regarding our PNS updates for professional nursing staff, this year we took on a lot of initiatives, 7 to 8 typically, than our normal 3 to 4. But I've been able to garner all this support and get our staff to get engaged and get involved with the process, receiving emails even from our ambulatory colleagues joining the PNS and getting involved, being excited. So we're really making some headway there. But one of our main initiatives was to improve our communication. And so we're utilizing what we call our nursing SharePoint site as a communication tool to highlight what's going on. So in the middle, it's hard to see, but we've moved our PNS tab from what used to be on the side up in the green banner down the middle, so it's very easy to find. We've relocated all the different committees for under PNS under there, and we've granted access to all nurses to see what's going on with that committee's work, to readability. And there's still some challenges with ambulatory, I think, getting into some of them, but we're making way. And not only for communication up, from the staff, bedside nurse, or the clinic nurse, but also back down from us. Thresholds was another big initiative that we took on this year and last year. Again, a community outreach, and it sounds nice because it's a magnet story, but the reason why we did it was there was a trend that we also noted, again, through Schwartz rounds of the persistent mentally ill population being admitted to medicine units, escalating under stress, and then attacking staff. And again, there really wasn't a good answer because of the decrease in funding for those units. And so we kind of took our road on the show on the road with them, coming to their community and then providing primary and secondary screening, education, health promotion, and then blood pressure checks, things like that. We've also donated $5,000 of our money, which is used for nicotine replacement that's not covered under law. And we're doing our 8th program now at the end of next month. And we get multiple disciplines, again, PCTs, NAs, CMAs, student nurses, mental health workers, as well as nurses coming to provide that. And again, these are just some pictures of people involved, again, because it's, the building, the tower, that's one thing, but it's our staff that really make the difference here for these people. Another thing we did was the bylaw revision every 4 years, a big deal, trying to update a lot of that terminology. The main changes were the PNS president term to 3 years because we found that it was difficult to find candidates given that long-term commitment. I know Rush Oak Park is a little different as they're getting theirs off, but we've seen that we wanted to reduce that slightly. Our staff approved to have the officers reflect themselves as a BNS minimum before election. We've included more of our APNs and ambulatory colleagues into the verbiage. We redefined some of these committees, operationalized the process for revisions, and then we put a little more teeth into some of these committees, allowing the chairs to manage their members a little better. We also took on Magnet, since it's our designation year, and so we're working on that, and Rush is actually very well represented this October at the conference with several podiums and posters. So we're very happy with that. And speaking of Magnet, this is one of the posters that got accepted this year. It's my poster, my doctorate program. And again, that's another multidisciplinary interdisciplinary effort that I spearheaded the nursing component, but it was physician, it was pharmacy, it was occupational safety and health, PCTs, a lot of players involved. But what I was able to show was that through nursing education, again, my focus was nursing, we increased their knowledge based on targeted education, changing the policy, updating all that, and then in practice, reducing the chemo spills. And if you look at the numbers there, the dispenses of our chemo agents, 700 to 9,000, that's a huge jump, and we've able to maintain that quality despite that. So it's very powerful results, and it's going to be shown at Magnet this year. The other thing we try to do is our professional practice model, which I'm very proud of here. And so this is our 3D model that Lisa helped me make because Marsha Murphy said this was a three-dimensional instead of two-dimensional. So we've done badge buddies, we've done a lot of education. There's a point on that SharePoint where I do a voiceover for nurses. I sent out a lot of emails with specific examples to different groups, mental health worker, psych nurses, labor and delivery, etc., just to give them specific examples of, again, when Magnet comes for the survey, we need to be able to speak to that model. And so I think we've done a good job of communicating that. And we just had the Magnet Fair, and there was Magnet Professional Practice Model Jeopardy there. Another initiative that we took on was our clinical ladder. We started it last year, and what it initially started out was just putting a little more teeth in the RN3 maintenance, and it just expanded to redeveloping and or updating all that language. We did use Rush Oak Park's standards that as our basis. And we redid everything. It took about 9 to 10 months. Again, helped spearhead with Patty, helping that occur. And we're just waiting on a few other legal issues with finances to go through with that, how we're going to deal with that. Another very proud initiative that we did was amp up our ambulatory colleagues into our existing Rush system, which is in the green, ambulatory is in the blue, and we were able to build them into our department advisory committee, to give our ambulatory colleagues a voice at the table. And I just received numerous emails with our awards that we just did. Several ambulatory colleagues got recognized, and they were very pleased with being included, not so a couple years back. And my last slide is, one thing we did not get to was improving our minimum, our lowest level, the unit advisory committee, trying for peri-op, IR, OR, RUMG colleagues, and then CSO. Again, as Cynthia said, is trying to fit a square peg in a circle hole, and it just doesn't work the way our inpatient model works. So we're still trying to figure out a good way to get that bedside or that clinic nurse a big voice at higher up. And that's me.
Thank you, Eric. Good afternoon, everyone, or evening, I guess it is. I am going to briefly talk a little bit about our Magnet journey. Eric mentioned that this is the year of our 4th designation, and I would like to just for 1 second take a second to acknowledge Jane Llewellyn, who is here in our midst today, because she is the one who brought us through 1, 2, and 3. And we are now very proud to be standing on the edge and ledge, one of the two, waiting, approaching the 4th redesignation for Magnet. And just, to put it into context, and, sometimes I think because we have been designated for such a long time, we forget how significant this honor is, and the work that Eric just described. You can just multiply that by the 2,000 nurses here in this organization and the work that they do every single day. We're only 6% of all hospitals in the country. Less than 400 hospitals are Magnet designated, and that includes hospitals that are in other countries. Saudi Arabia, I think there's 2 hospitals in Israel, and the very first hospital just got designated in Canada. So it is a very elite group that we're a part of, and we're very proud of that. And talking about Jane's accomplishment, the first designation was in 2002, and we were the 51st hospital. And so you can see that not only do we have the privilege of being amongst the best, we actually were trailblazers in that regard. So kudos to Jane and all of Rush, and we just want to continue her legacy and move to the 4th designation. So thank you, Jane. This document is a web-based document. It's very different this year because we are functioning under a different document, a different set of standards that we learned about in the summer of 2014, and but we submitted our document successfully in February of 2015. And we received our documentation back asking for additional documentation, but it were very, very minor things. And so just another acknowledgement of Melissa Browning and Patty Nedved. And Patty has been a leader in getting us to this point. So thank you to both of them for their hard work. So these are the categories, and just to give you some sense for how much is packed into this little document here. A lot of the document, it now has transitioned to really being focused on data and being able to demonstrate outcomes and demonstrate that the so what of being an excellent nursing service. And so 50% of this document is tied to data. And so it's very appropriate that Diane brought up the issue of trap use earlier, because that is just an example of one of the stories that is a part of our Magna document, where you can see where our trap use percentage, our percent of our trach patients that were developing trap use, and then after our intervention in June of 2011, that we have really sustained less than 1%. Trap use. So really good outcomes, and we're very proud that we have multiple stories like that included in this document. So we are looking forward to our site visit someday soon, and hopefully it will be in the fall of this year, 2014. And as we are waiting for our 4th designation, Rush Oak Park is waiting their 1st designation. They have also submitted their document, and Rachel is here, and congratulations to Rachel and Karen for continuing the journey and continuing the legacy of Rush Nursing and Rush Excellence. And we're just very proud of all that we do here at Rush, and I am so proud to be a part of such a fantastic nursing service. So thank you all very much.
Thank you both for your leadership and participation here this evening. Do we have any questions for Eric, Dr. Bargener? Does anyone from a different setting have a story to share related to either interprofessional practice or their shared governance model or a magnet journey?
I just want to say kudos as a nurse for 15 years here. The impact of Schwartz rounds was important, and we really appreciate you taking leadership on that, Eric. There has been every single month I've heard from nurses telling me, oh my gosh, you should have seen Schwartz rounds, and everybody was bearing it all, and it meant so much to hear what everyone was doing. And I just want to echo, the community's appreciation for your courage to, go out there and really do what we're supposed to be doing with evidence-based practice and finding something. So it's impacted everybody beyond nursing. So.
Thank you. I just want to say, too, the point of Schwartz rounds, though, is to provide clinically excellent care, but we do so that we need to acknowledge our own issues to take care of ourselves before we can take care of others, and it's a public forum, so yeah, the debriefings that you mentioned earlier, those need to also occur, but it's a separate to bringing it out here for other people to learn from. Thank you.
Mm-hmm. Mm-hmm. Yes?
I just got a question. I'm wondering how the lessons that we take from Schwartz rounds translated into food training? Because I imagine there's a lot of richness there that applies, most of all, learning how to better communicate in a interprofessional environment.
Well, what I've seen with Schwartz rounds is that now when you get people in the same room talking and sharing and just collaborating, now the nurse on the unit's not afraid to go up to the attending and say, you know what, this bothers me, can we talk about this? Things like that. It is happening. So, or PCT, there's no of those typical power that we would normally see. They're not afraid to approach each other. So.
It seems that to shift a culture toward interprofessional practice and education means shifting attitudes and thinking about how we care for patients and the patient experience, and it takes multiple strategies. So this is one strategy, the crew training, all of the work in the college that obviously is so synergistic with everything we do in the hospital.
No, I was just going to say that, you know, from the perspective of interprofessional, and this started out as a nursing initiative, as Eric mentioned, but it truly is an example of an interprofessional learning experience. And the reason that there are so many different disciplines there is because they all need that same opportunity to learn and to express their concerns and to do it together.
The other thing too is it may be just another Monday for you and I when we take care of these patients, but and we've seen their perspective that they're facing life and death at that time, and so it's we're humans, we're caring for humans. It's difficult, and as you all know, times have changed. These patients are more challenging. Different times of nurse, we feel the pressure of the organization's expectations, but we still want to provide the best care we can. And ultimately, you know, it comes down to trying to be with that patient and help them through that experience and empathizing with them to the best that we can.
Another wonderful and I think closure to the event and panel. Thank you so much. And thank you all for attending this evening. I think it was just a great dialogue. Thank you to all of our presenters, and thank you again. And we have an opportunity for networking.